Bon, donc bonjour, je m'appelle Gustavo Turecki et j'ai le plaisir d'introduire Dr. Barbara Stanley. So Barbara is a professor in the Department of Psychiatry at Columbia University. She directs the Suicide Prevention Training, Implementation, and Evaluation Program, the Center for Practice Innovations at the New York State Psychiatric Institute. Barbara is a prolific scientist, has published more than 150 papers, has several grants from NIH dealing with suicide, intervention, and also focusing on etiological causes. Barbara is also the editor-in-chief of the Archives of Suicide Research, a fantastic publication with high-quality papers in suicide research, and has received many awards. Barbara's work is well known because she's developed the safety planning intervention, and this is it's an intervention that has been adopted by the VA across the United States and is also used in crisis hotlines. So really work that has had tremendous impact in the field of suicide research. Now, as a researcher working in suicide, you get a chance to meet a lot of people. Yeah, so that's one of the perks and nice things about being a researcher. And you do meet, a lot of people. You collaborate with a number of people. There's always these special people, yes, special people with whom you have a connection. And Barbara is part of these special people for me. Barbara is someone who is first, a fantastic person to work with, and we had a chance to work over many years at the ISR, but also a very rigorous scientist who is always there and does a fantastic job at everything that she does. So it's really a pleasure to have you here, Barbara, and we, in the name of everybody, I want to thank you for taking our invitation. Please.
Okay. Thank you very much for that lovely introduction. So I'm going to say, bonjour. Now, French is my absolute favorite language, and therefore, that's all I'm going to say in French. When I was in college, I started out actually as a French major, and my college counselor said to me, "So are you going to become a teacher?" It's like, "No, I don't want to become a teacher." She said, "Well, what are you going to do with the French language?" It's like, "Oh, well, maybe I should think about that." I just loved French. Okay, so today I'm going to talk about brief interventions and their role in suicide prevention. I am going to talk in the latter part of my talk about the intervention that Greg Brown and I developed, but I kind of want to set the stage for you about why we think about brief interventions and also what other people have done in developing brief interventions. So this is where my funding comes from, and my co-developer is Dr. Gregory Brown for the safety plan intervention. So I'm sure you've heard about this already today, about the tremendous problem that suicide is worldwide, but I thought I would put up a figure of what's going on in the United States. So in the United States, and it's pretty different than actually the rest of the world. We have, if you look at all those other causes of death, accidents, diabetes, heart disease, they're all going down. And the only one of the leading causes of death that is rising in the United States is suicide. And it's pretty astronomical rise. So we're we're not doing such a great job in preventing suicide in the States. So we keep looking for other kinds of things to help prevent suicide. Okay. So the way I like to think about this is when we think about preventing suicide, and this is kind of mostly thinking about it in the healthcare system. So this is what I think about as the suicide prevention wheel. And these are all spokes on the wheel to prevent suicide. And so the first three are kind of like are screening or assessment. I'm not going to talk about those. The rest of them are interventions that we do. And I put this up because it's really important to remember that preventing suicide is not one small thing. It's a bunch of different things that we need to do. Sometimes you will hear people talk about doing screening. If we do screening for everybody, we're going to prevent suicide. Well, no. If we do screening for everybody, we are on the road to preventing suicide. It's just simply the first step in preventing suicide. So my talk is focusing on brief interventions today, but you can see that there's emergency care, there's psychiatric hospitalization, there are suicide-specific pharmacotherapy, brain stimulation, and suicide-specific psychotherapies. And so these are all parts of what we can use to prevent suicide. So the way that I think about this is if we think about suicide as having suicidal thinking or suicidal risk as having kind of two components. There is the acute risk of somebody in a suicidal state. And so this is on the x-axis there, it's minutes or hours. And so if you talk with people who are suicidal, who get suicidal, there is a kind of a rise to their suicidality, and then it comes back down over time. Now, at the end, I'm going to show you what it looks like in different people. Because for some people, this rise is very, very slow. For other people, it's up and down over the course of minutes and hours. But there is a point at which, and when I talk with patients about this, I talk with them about the suicide risk curve. And it's this place here where they are in danger of acting on suicidal feelings. The thing is that's really very interesting is if somebody is restrained from, say they're very, very, very suicidal, and they are restrained from acting on their suicidal feelings. As soon as they are unrestrained, do they try to kill themselves? Basically not. Now, what happens is that for just like all of our emotions and all of our thoughts, suicidal feelings subside. And so the idea here is, okay, so what do we do to help people? I think it's not. Okay, there we go. To help people through this period without acting. And this, I think, is where brief interventions come into play. So it's when people notice that they are getting suicidal, that they are in an acute state, and then what do we do? So this then goes hand in hand with fast-acting medications like ketamine, emergency care like the emergency room or even psychiatric hospitalization, and crisis interventions, brief interventions. And that is opposed to, and if you notice here, this is weeks and months on the x-axis. The kind of more elevated chronic suicide risk. And so here what we need are disorder-specific, suicide-specific psychotherapy and medication. And so you have things here like persistent stressors, hopelessness, depression, PTSD. And so what I want to really stress here is that I'm not saying brief interventions are the be-all, end-all. They fit into the kind of like the toolkit that we have for helping suicidal people, but we also have to address the underlying problems. And so the way that this kind of works, if you think about this, you have acute risk interventions, chronic longer-term interventions, and what I'm not going to talk about today is how do we build emotional reserve so that it minimizes the chance that somebody comes back into having acute risk, and if they do get here, if they have built skills and reserve here, then they will be better able to manage here. Okay, so this is where my focus is. So what's the role of brief interventions? There are many different things, and it depends on the particular intervention that you choose. They have served different purposes. It's to reduce imminent risk, to increase, now the intervention that Greg Brown and I developed hopefully does this to increase suicide-related coping and increase skills, to enhance help-seeking or treatment engagement, and then to provide a follow-up safety net, which is actually very important. I don't know what it's like here, but in the emergency department in the United States, if somebody goes in for a suicide crisis and they don't require immediate hospitalization, what typically happens is they're given a referral, or maybe they're set up with a referral. That referral doesn't happen right away. It can be a week, 2 weeks, a month, sometimes even longer. And so if we know from our data that somebody makes a suicide attempt or has a suicide crisis, there is this period of risk that is anywhere from, say, 3 to 6 months. So think about this, like how much sense does this make? They come into the ED, they don't need to be hospitalized, and that's a sound decision. And then we send them home with a referral that they can get into care maybe a month down the road. So you have this elevated risk here, the clock is ticking, elevated risk, elevated risk, elevated risk, waiting, 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 waiting. So, okay, that's the nature of the healthcare system, but what can we do in between? So there are ways of providing follow-up. We do it by telephone, people do it by text, to help somebody along the way while they are waiting to get into care. Okay, so what are the characteristics of brief interventions? So what I'd like to try to do is distinguish this from crisis interventions. So the crisis interventions typically happen on when they call the crisis hotline, and what often happens on a crisis hotline is the person gets talked down from wherever they are. So the crisis gets diffused, and then often the call will end because the person is no longer acutely suicidal. And so that's great. But the way that I like to think about a brief intervention is what can we give the person after they end the interaction with us that they can take away from the interaction, that they can use. And often, now some crisis hotlines are doing safety plans on them, but often that doesn't happen on a hotline. So that's why a brief intervention is different. So it can be psychoed. These are risk factors, protective factors, what applies to you, how can you help yourself. Crisis response planning, which is safety planning. Somebody developed a single session CBT. Motivational interviewing, which is to help people get into treatment. And outreach follow-up, which is letters, postcards, phone calls, and some combination of them. And so I'm going to talk about each of these. Okay, so why do brief interventions? So one of the things, so I've been talking about now, okay, so this helps somebody get into treatment. But if you work with suicidal people, especially in the ED, there's a subset of them that are either they're finished with the mental health system or they don't want to engage in the mental health system. And so it's not an uncommon thing for somebody to go to the emergency room, they're acutely suicidal, and they do not follow up on treatment. And so what do we just give them a referral anyway? We can do something more. We can do some sort of brief intervention that they can walk away with. And so these are some of the things that patients have said that to me. Been there, done that, no thank you. There's stigma associated with being in outpatient care. I don't want to do it. It's not my cup of tea. Or for some people, it's truly inaccessible. Like in rural areas, people can't really get to treatment. So the other problem that I think is really very important that we really haven't adequately addressed in developing our interventions for suicidal people is that men are much more likely to die by suicide than women. At the same time, who is populating the offices of psychotherapists and psychiatrists? It is not men for the most part, it's women. So men don't seek help, women do, men kill themselves. What are we going to do? And so the way that I have kind of thought about this is, where do you find men when they're seeking help? Where do men go? The only place that I could think of that men actually go for help is AA. And they go to AA. And so somehow, in developing the safety plan, one of the things that we thought about, it was that, so they like to get help themselves. They like to help themselves, not have somebody up here, a big health professional, telling them what to do. I actually am not quite sure about what it is about AA that makes it okay for males to go there. But all I can say is, if somebody's thinking about developing an intervention for suicidal people, that we should be looking there in some way or another. And in fact, when we were implementing this in the VA, I don't know if you know from in AA, they talk about working the steps. And I overheard these guys in the lobby one day who were from the mental health clinic, and they were suicidal, and they were talking to each other. They didn't know I was listening in. And the guy said, well, okay, like, I'm working my plan. I'm working my safety plan. And so they have that same kind of mentality. They developed it on their own. They didn't say, oh, well, Stanley thought that AA is a good way to think about this. So there is something about that. So there's a problem with treatment engagement. I already mentioned this. Many people drop out of treatment very quickly. They go to one appointment, they leave. And if you work with adolescents, you know that last week is ancient history. And so to keep them engaged in treatment is not the easiest thing. And so my thing is, with suicidal people, is you have somebody sitting in front of you right now. What are you going to do with them to help them not make another suicide attempt, or to help them mitigate their suicide risk? Brief interventions are both accessible and low cost. And it's actually been a lot of the missing part of the suicide prevention process. So we're doing bad when it comes to developing treatments and interventions for suicidal people. And this is an overestimate of the number of randomized controlled trials for that are suicide specific, and an underestimate for anxiety disorders, eating disorders, and schizophrenia. And when you think about it, in our field, what is a more important problem than helping people not die by suicide? Okay, so now I'm just going to talk a little bit about what are the different types of brief interventions. So I'm starting with the one that is my least favorite, and it's the caring contact letter interventions. And I'll tell you why as we go through it. So this is a very famous study by Jerome Motto, and so these were for people who didn't go into treatment. They sent them a letter every few months. It's kind of just like this. We'd be happy to hear from you, semi-personalized letters. And this is what they found, that over the course of several years, the people who got the letters were less likely to die by suicide. So, and there's a series of letters that they got. And eventually, over time, those curves collapsed onto each other, so the effect, whatever effect there was lost. There's another study called Postcards from the Edge, Greg Carter, and they did a similar thing, but they were looking at intentional self-poisoning, and this actually wasn't quite as positive. They had this for the number of episodes. So you had people who had like a lot of episodes of self-harm, and then people who had a few. So the high episode people, high frequency episode, were more likely to diminish the amount of self-harm. It's not suicide attempts. And the effect was stronger in women. And so the results have been, were partially confirmatory. So and I will just share with you why there's something that always bothered me about this, like how could a postcard help? And so I guess as long as you continue it, it conveys some sense of caring. But what I feel is the same thing that I feel like when you have somebody sitting in front of you in the ED, you could be really nice, really empathic, really validating, understanding. What are you going to give them that they're going to take with them when they leave your office, when they leave the emergency room? And so to me, it feels like I am just, and this is my personal orientation, personal bias, I am much more skill-oriented. I want to give them something so that when I'm not there, I don't have to be around being they don't need a caring contact. They can develop skills within themselves. And there's just something about it that doesn't quite seem correct. Like how can a postcard possibly stop somebody from killing themselves? It intuitively doesn't make sense to me. But the data are the data. Okay, so then there are telephone contact interventions. VEVA did a really nice study, did telephone contact for patients discharged from the ED. And it was pretty experienced people that who did the telephone contact. It was psychiatrists with at least 5 years of experience in managing suicidal crises. So they put very experienced people. And so they had a supportive approach. They reviewed treatment recommendations and so forth. And then they found a lower reattempt rate in people who had this intervention. However, when you look at the intent to treat, which means the people that that were enrolled but they lost to follow-up, it drops out of significance. So it's positive looking. Okay, so then the most the way that people are developing interventions now, and that's what our intervention is doing in-person interventions. And so there is the SuperMISS study where it was conducted in low and middle income countries. And so this is basically when we say they got treatment as usual. In Canada or in the United States, there actually is some treatment that people will often get. In these countries, treatment as usual would have been basically nothing. And so it's doing something versus doing nothing. And so they did a 1-hour individual information session with them, it was psycho-ed. And then they did 9 follow-up contacts, either by phone or visits. And they also got an effect. They got an effect on suicide rate over the course of time. So at a year and a half, it's a pretty significant effect. Small n, that's the problem with doing these kind of studies. There are, even though it's a terrible problem, it's still a low base rate illness. Okay, so the next one is a newer intervention that was developed by Craig Bryan. It's called crisis response planning, and it actually is very similar to the intervention that Greg and I have developed. These are the elements of it, and I'm putting this up so that you could see that there are certain common elements. It's supportive listening, which of course is the basis of any intervention with a patient. So looking at warning signs, self-management skills, reasons for living, social support, what are your crisis resources, and giving a referral for treatment. And so this is a crisis response plan that they have developed with suicidal. They developed this in the military, so it was suicidal service members. And they also found an effect over 200 days of decreased suicide attempts with the crisis response plan. Interestingly, what they chose as their comparison group is a no suicide contract. Does anybody do no suicide contracts here? In the United States, they were very, very popular, and actually people still do them. And so it was an interesting comparison that they chose. And then there is another group, Ed Boudreau in the University of Massachusetts has this huge emergency department study doing screening in the emergency department, and it's called ED Safe. And so for their earlier version of this project, they did a suicide intervention for a subset of people. And it consisted of three things. They did an extra screening. They did a self-administered safety plan called a life plan. And then they did a series of phone calls. So you can see the similarities across them. So, but it went for a long time, for 52 weeks. And so the calls focused on, The calls focused on identifying suicide risk factors, clarifying values and goals, safety and future planning, and facilitating treatment engagement. This is what the life plan looked like. What are the first signs of trouble? In other words, warning signs. What's my plan of action for keeping safe? So it's kind of much more generic. And then this is who I can contact if I can't manage. And again, they got positive results. It's pretty labor intensive, and they had a pretty significant dropout, because if you think about people coming to the emergency room for a suicide crisis and then trying to follow them repeatedly over 12 months on the phone, it's a difficult population to follow that way. But nevertheless, they got 30% fewer suicide attempts in the follow-up period. So I guess what I would say is, if you just look at these things, they're pretty impressive for something that is relatively low cost, relatively time efficient. And if you compare it to, say, something like, what does it take to teach a clinician to do, say, DBT or cognitive therapy, it's a lot of work to get somebody to do that effectively, and then it's a lot of time and effort to deliver it, and then you have people who will drop out of treatment. And so this is, and I'm not talking about these interventions as replacing them, but boy, some of these results that you can see here are as good or better than what you would get for some of the larger scale treatment. So this is the intervention that Greg Brown and I developed. This is the actual form. People have adapted it in all different ways. On the top, we have people identify warning signs. We have people go through this in a hierarchical manner. And so ours is, I would say, of the safety plans that are out there, ours is more structured than other people's. So we have people identify what their warning signs are, and then we have them identify, when they get into trouble, what are things you can do by yourself, just by yourself, nobody else. And so you want people to learn to do things within themselves instead of just, on every doctor's office in New York, it's like, if you get suicidal, call 911 or go to the nearest emergency room. We can do better than that. It's like, would I ever tell an anxious person, if you get anxious, call 911 or go to the nearest emergency room? No, you teach them skills. And so this is, what are the kinds of skills? that you can use. And then we teach them to use people in the same kind of way that they use skills. So people as distractors. In other words, people who will take you outside yourself. These are not people that you're going to tell that you're feeling bad. These are people that are going to take your mind off your problem as the same thing as a video game would. But it's a person and you're interacting. And then people who can help them. And then the mental health system, the emergency room, and so forth. And then we also have them identify, we do means restriction counseling with them at the end. And Greg Brown and I had a lot of discussions about this in the beginning, and he was very, very insistent on putting that at the end of the safety plan. Because if we could show people, look, there are things that you can do when you're feeling suicidal, instead of acting on it. His thinking was that people would be more likely to engage in a discussion about how to restrict their access to means. Okay, so this is just one of our articles. So we do start within self, and then we move to other people, and then mental health professionals and so forth. And so it is like rely on yourself, rely on your own resources, rely on the people in your natural environment, and then turn to health professionals. And so if you think about it, if you do this over and over and over, the person is learning. It's not just like, oh, this is their crisis. This is a learning tool. And so the way that we thought about this is like I don't know if you have this here, but we have Fire Safety Week, early October. And so when my kids were growing up, my house was up on a little hill. And I always knew it was Fire Safety Week because they would come get off the school bus and I would see them rolling down the hill. It's like, what are you doing? Oh, we're stopping, dropping, and rolling, Mom. And so the idea, though, is why are we taught that? Or like on the plane today, when the cabin pressure goes down, before you put it on the child next to you, and so why? So that we don't have to think in an emergency. It's just like when somebody is in a crisis and when they're suicidal. We don't want them to have to think, what could I do now to make myself not suicidal? No, we want them to have a plan. And so I won't talk much about this because I want to show some of our data, but this is like really, it's very interesting, how things kind of work out. We didn't start out saying we were going to develop a brief intervention for suicidal people to mitigate suicide risk. Not at all. What we were doing was we had developed a treatment as a cognitive behavioral treatment that was kind of like an amalgam of DBT and CT for suicidal adolescents. And it was really actually the first trial of depressed suicidal adolescents as outpatients, and they had to be recent attempters. And so we wanted to maintain them as outpatients. And so we were thinking like, okay, so how are we going to keep them safe while they get the real treatment? And so we developed this safety plan. And Greg had already had kind of an earlier type of version of this, but the safety plan that exists now was done to help them keep safe while they got the real stuff. And then lo and behold, at the end of the treatment, we did these interviews with the teens as they were leaving, and they said, okay, so what part of this treatment helped you? And they kept saying, oh, the safety plan. The safety plan really helped. So we were giving them the skills, we were helping the family get better and all this stuff. And so that had us scratching our heads and saying, well, I wonder if this is an intervention to think about in and of itself. So this is like one of those things that we had no idea that it was going to be adopted in the way that it was. And one day I was talking about this we had a meeting, and the head of suicide prevention in the VA was there, and she heard me talk about this, and she said, you know what, the veterans need this. And then the next thing we knew, before there was one bit of efficacy data, every veteran who was suicidal in the VA was getting this. But we did take evidence-based strategies and incorporate them in the safety plan. So the safety plan itself, when it was introduced, didn't have an evidence base as a package, but the parts that went into it were evidence-based. So means restriction has an evidence base, teaching brief problem solving and coping skills. We put a big emphasis on distraction. Enhancing social support, of course, is good, and motivational enhancement for further treatment. And so the theoretical approaches that underlie, and I put theoretical kind of, it's a small t in terms of there's no real theory, but suicide risk fluctuates over time, as I showed you earlier. Problem-solving capacity, we all know, diminishes during crises. And then we know that cognitive behavioral approaches to behavior change work. So this is the typical, so we did this a lot. We started a project in the emergency department. And because what we thought was, what happens in the emergency department when you are suicidal? That you assess for imminent danger, you refer for treatment, but you know that a lot of those people are never going to follow up on treatment if they don't get hospitalized. And the thing that I always think about is this could be your only shot with this person. And so I was thinking, so to talk to emergency room physicians about this, to try to sell it, is not so easy. But when I went and I spoke with them and I said, okay, so somebody comes in and you look at the x-ray and you say, oh, that leg looks like that bone is broken. And so would we think about saying, oh, we're assessing for imminent risk. You definitely do not need surgery for that. That bone, it just needs to be reset. Here's a referral, go get it set. No, it's set in the ED. And so we think about, okay, so what are the kinds of things that we can do in the ED for our suicidal patients? And so simple things like a safety plan is what we were thinking of. Okay, so these are the overview. I already went through this with you. The really important thing is now, when you do a safety plan, has anybody ever done a safety plan with patients? Okay, so have you tried to use this safety plan or different ones? How many have used this one? Okay, so the thing that we have found when people do safety plans is that because it's on a form, if you do a lot of them, it can be treated as a form. It's not. If you think about it as a form to be filled out, don't bother. You have to think about it as a clinical interaction. It is an intervention that you are doing. You and the patient are collaborators on it. And if you don't have that mindset, or you don't have the time for the mindset, to develop that mindset, it doesn't really make sense to do this. So you have to treat the person as a partner. I always start out with suicidal crises come and go, so I get them into the spirit of why we're doing this. And instead of saying, oh, I see you're suicidal, I'm going to give you a safety plan the next time you're suicidal, you can use it. They have to understand why you're doing it. They have to be put into the mindset of it. And then you explain to them. So there's a little bit of psychoed that goes along with it. How it helps preventing on acting on suicidal feelings. One of the things when I have had people, when we've talked with them afterwards and asked, okay, so was this helpful? What they say is, you know what, I used to get through these crises by white knuckling it, like just hanging on. And now I realize I can do something instead. And so it creates a sense of self-efficacy. So we talk with them about it. This is before we pull out the form. And so the other thing, which is any good clinician will do, is you don't make assumptions about what's underlying their suicidal behavior. You ask questions, and then we start with obtaining their narrative. And so here's here's an example of somebody's narrative. I can't take it anymore. So we have them tell their story, their suicidal story, and so. This takes a little bit of time, 10 minutes or so. But the reason that we do this is we are listening to them with our clinician's ear about what their warning signs are, because they're not necessarily going to know what their warning signs are. So it's an immediate rapport builder, and you are learning what their warning signs are so that you can complete the safety plan. And this is an example of somebody's safety plan from this narrative. I can't take it anymore. I can't stand being so upset, so easily like this I get angry and depressed. And you could see where it right comes off this narrative. Okay, so I just want to spend 1 minute on this. This is a totally different project. But one of the things when I present to psychologists, one of the things they say is, oh, you're teaching people to use distraction. That's like bad, to teach people distraction. That's not really helping them solve problems. And so I figure the people who say that never raised a 2-year-old, because one of our best strategies as a parent is the child is over here wanting something, and you say, oh, well, how about this, honey? And the next thing you know, they're on to the other thing. So distraction, and what happens to those powerful emotions of wanting, and angry, they're gone. And so distraction is wonderful, not as a tool to cope in life permanently, but to get through a period of time, it's great. And so when we looked at, so from a totally separate project, I did, and I had no idea, again, that these things would relate to each other, but we were doing ecological momentary assessment with patients at a baseline of a treatment study. So that's where you give them, it's in their phone, or you give them an iPod, and you ping them 6 times a day, and you have over the course of a week, and you have them rate a bunch of different things. So we had them rate their suicidal ideation, we had them rate what their triggers were, what was going on in their life. We didn't ask them to identify that these were triggers, and then what their coping was, what kind of strategies they used. And so it's amazing data. So you could look at the trajectory of suicidal ideation over the course of a week. And without asking somebody what worked for you, because we're not the best reporters, you look at the data and you see suicidal ideation is here, this was the strategy they used here, their suicidal ideation went down. And so what worked for people was distraction, keeping myself busy. And all of these kind of worked, but when you put them together in a joint model, keeping busy, distraction. And so it's a kind of a validation when you are in that kind of acute state, this is a good thing to do. Okay, so we had, I'm going to talk a little bit about the project and present some data on it. So what we did was, the project is called SafeVet. We did this in the emergency department of several VAs across the country, where we implemented safety planning only for people who were going to be discharged. So we wanted to kind of tackle the moderate risk patient. And so we did safety planning in the emergency room, and then we did a series of follow-up phone calls. The idea was we would just do phone calls until they had their first treatment appointment. And so this is what it looked like. So they did the typical risk assessment in the ED. We did our brief intervention, and then whatever happened. If they were referred out, we followed them up until they were engaged in care. Importantly, our phone calls were not psychotherapy. They were not psychotherapy. They're kind of structured, and they were goal directed. So what we did was we checked in about their mood, but mostly we were just checking in about their suicide risk. In only a handful of patients did we need to do emergency rescue, but we did that. We reviewed and revised the safety plan. So this was really good because it reminded people that they actually got a safety plan, and we got them to get it out and go over it with us. And then we helped them get into treatment. And so we did a little motivational interviewing. We helped facilitate, like removing barriers to care. Calls were made within 72 hours of following discharge. And so it was, so this part is very difficult to do because in the United States, this is nobody's job. It's not the emergency room's job to do follow-up phone calls. It's not the outpatient clinician's job. It's not the inpatient clinic. It falls nowhere, and it's not the crisis hotline's job. So that's really the only problem with this, because otherwise it's really good. Okay, so I'm not going to go through all this. We enrolled a lot of people. And so, as I mentioned earlier, we want to reduce suicide risk, so our goal was to look both at reducing suicide risk by looking at suicide outcomes and increasing treatment engagement. So we looked at whether they got into treatment more likely if they had this intervention. So we had several EDs that got this intervention, and then we matched them geographically and in size to EDs that didn't get this intervention. It was a massive project. And so here's what we found. We found that there was about, and so this is a low-intensity intervention, right? 45% fewer suicide behavior reports. This is the way that the VA reports suicide events in a 6-month follow-up. And so it's pretty significant for something that is, maybe it took an hour and a half of time. And then we also looked at whether these people were more likely to get involved in outpatient care. And in fact, they were. And so not only did it reduce their suicidal behavior, but it increased the likelihood of getting into outpatient care. So my statistician was who was kind of like, she's like the conscience. She said, okay, let's see if it's just getting into outpatient care that made them less likely to have a suicide event. And so she did a mediational analysis, and in fact, it's not true. It was the safety plan had an impact irrespective of whether they got into treatment or not. Okay, and then we did a part of the study. This was just, we didn't do interviews of patients. We just took them, we got information from the medical records. Then for a small subset of patients, we had a separately funded study, and we wanted to see, okay, so how was safety planning worked? If it worked, what was it doing? And so we were thinking, so would it affect suicidal ideation? Not necessarily. Because if you think about it, the person is entering a crisis, they're still going to feel suicidal. And so we said, okay, what it does do is it enhances their ability to cope. That's what we're thinking. And so there was no suicide-related coping scale, so we developed one, and that's published now. And in fact, that is true. That is what happens. People who were who got safety planning definitely had better ability to cope with suicidal crises. We are still looking at the data now to look at suicidal ideation, and in fact, I don't think we're going to get effects for suicidal ideation. I think the suicidal ideation is going to be the same, but we get this type of effect. And then the last thing I just want to talk about is a little bit about safety plans themselves. What's the nature of them? So we interviewed a bunch of people and asked them, have you used your safety plan? Do you know where it is now? And so forth. And so 20% of them said they made changes to the safety plan, which is really what we want people to do. Almost 20% of them said they thought about using it and they chose not to use it because they didn't want to appear weak, or they felt they used the strategy that wasn't on the safety plan, which is fine, so they should be coached to add that into the safety plan. And so, okay, so then we asked them, did they know where it was? And everybody could identify where their safety plan was. So this was on phone. So we thought, okay, so they could just be saying that to us. So we asked them to get it, and we had a copy of it. And so they could tell us, so they would get the safety plan, and then we would know that, yes, in fact, they did have this safety plan because we could check to see what they had put on as their coping strategies and so forth. And so almost 2/3 of them reported having used it once. And this is, I thought, really interesting. So if you look at like what aspects they found helpful, and I have a colleague in Melbourne who has a safety planning app, and they're getting very similar results, where people are saying the social contacts and places for distraction or social support are what's most helpful. I kind of thought that the internal coping strategies would be most helpful. What I think is interesting about that is like everybody has social contacts, but I think what they will say is like, because it's on the plan, it kind of gives permission to contact people. And often when we develop a plan, we will ask people to share with whoever it is that they are putting on the plan, that they are on the plan. And then lastly, I just want to mention that quality does make a difference. So you can't, as I mentioned earlier, you can't just do a safety plan, give the person the form to fill out, and here's a safety plan, fill it out by yourself. Suicidal individuals indicate that plans are most helpful when developed as a partnership. Higher quality plans, these are people who are doing their own research on safety planning. Higher quality plans are related to fewer subsequent hospitalization, and more complete safety plans were related to outcomes, specifically people and places as distractors predicted decreased likelihood of suicidal behavior. So I just want to end by talking about the kind of like the many faces of suicide. One size does not fit all. And so I've been talking about this brief intervention as helpful, but it's like it may not work for everybody. And I can think of a few instances where it might not be helpful. But this is what I wanted to show you, what I was talking about earlier. From the study that we were doing with getting the assessment over the course of a week, these are two individuals' suicidal ideation over the course of a week. And so this is somebody who has elevated suicidal ideation. It's relatively stable. It doesn't go up and down. And this person, I mean, I can't even imagine what it's like to be in their skin, where suicidal ideation is bouncing all over the place over the course of a week. So I don't have the answer to this, but, you know, it makes me think, you know, I wonder in whom will the safety plan be a better intervention? In a certain way, I'm thinking this person as opposed to this person, but, you know, we don't really know. So just to summarize, the take-home points are brief interventions at this point I think are promising. They seem to reduce suicidal behavior and increase treatment engagement over the short term. Over the long term, we don't know. Nobody has done long-term studies. Most efficacious interventions have some form of safety plan that patients keep with them. And brief interventions can be helpful when clinical treatment is scarce or unacceptable. And it seems like integrating follow-up phone calls also helps. At the same time, it's really important to remember that we shouldn't expect too much of a brief intervention. You know, when I give these talks, people say, well, does safety planning reduce suicide? Well, okay, that's a good question. But, you know, the way that I think about it is it's one spoke on the wheel. It's just like cholesterol-lowering drugs for heart disease. You know, it's one piece of an intervention that you should think about somebody at high risk. And then additional interventions, and we can never forget this, to address the underlying suicide risk factors and psychiatric illnesses are important. Here are some resources for you. Thank you.
for this fantastic lecture. Okay, so thank you very much for this great lecture. We have time for questions. First, let me ask the people who are on the other sides. Est-ce qu'il y a des questions? Do you have questions? If not, we'll proceed here. Questions here?
We use suicide prevention contracts. I work in a mental health setting, adult mental health, in the community. And one of the questions that we explore with people are the reasons for living. And I was curious that how is that left off, or is that explored in your SPI?
Yeah. So actually, the version that I showed you doesn't have reasons for living. But at some point along the way, I don't know who did this, but somebody put reasons for living at the bottom of one of the forms. And that form has gotten very, very widely distributed. And so that is, in the original form, we didn't have that. But people who are suicidal will say, oh, I really like having the reasons for living there. I think that it's, I think it remains to be seen because it feels to me like if you have somebody who, when you get through this whole plan and you've got them all kind of like jazzed up, like, okay, I can fight this, and you say, okay, so now we're going to just talk about your reasons for living. It's like, well, I don't really have any. And so it requires extra working with some people. Pets are a big one as a reason for living. Oh, yeah, definitely.
Est-ce qu'il y a d'autres questions?
I want to know how we can increase the treatment motivations. Can you give an example?
The treatment what?
Motivations.
Yeah, so that's a really good question. You know what, of course, it depends very much on the reason for not wanting to go to treatment. If there are structural barriers, like, caring for children and distance and all, those are like relatively easier to tackle. We use pros and cons, motivational interviewing. Those are the kinds of strategies we typically use. So it's the hardest person, I think, to engage is the person who has had many disappointments with seeking care. And those people, in my experience, they'll call the crisis hotline, but they won't do much else. So, I don't have any kind of magic bullet to say, but it very much depends on a conversation, and it can actually be quite a lengthy conversation because you really have to understand what the individual's reasons are. Sometimes they think, it's not going to help, and so it's any number of things.
I think you can hear me. Can you hear me?
Yeah, I can.
Okay. So, me working.
Yeah, that's the big one.
Okay. Sorry. I work in a community environment with youth and also with adults, and we often encounter individuals that refuse getting treatment or even taking the steps towards help. And I'm looking at the suicide safety plan, and if after the refusal and the encouragement towards seeking help, it's something that it's not for them, like they say, would you have any tips for community workers and interventionists on using this suicide safety plan as a tool? I know you're saying it's not a tool. It's it's a process. Any tips that you can give us for using this suicide safety plan?
So, to help people get into treatment for what? To get people to do it?
No, to use it. I've never used the suicide safety plan, and we encounter youth and adults that they say it's not for me. I've gone through it, and it hasn't helped me, and they still come to us looking for help.
Right. Yeah. So I love working with that population, and it's an advantage of being older. It's like, because they will say, it's in the past. It's never going to happen again. And so that is a frequent refrain. That was last week. Gone. And so so I will stop, take a step back and say, okay, and I'll do a little psycho-ed about what's one of the things, you go to school, right? So do you have fire drills in school? Why? Has there ever been a fire in school? No. Why are we doing that? Because in the rare possibility that a fire occurs, we really want you to be equipped to know how to get out of that building safely. And so we hope, and we're almost positive that it's never going to happen. But if it does, we want you safe. And so that is the example, or something equivalent to that I use with people. And I have to say, I've never had anybody say no.
Thank you.
Oui, j'ai quelqu'un ici. Il faut le mettre prêt pour bien.
So just to follow up, one last thing about that is, so I don't argue with them about, hey, you have had 3 suicide attempts. They were only 4 months apart. It's not at all. I don't go there. I just kind of accept what they're saying and then use that.
Hi. With some people who can benefit from social support, would you recommend still doing the plan alone with the patient, or try to involve other people around them when you're doing the elaboration?
So people who, I didn't hear the...
Oh, sorry, that might be my French accent. So people who can benefit from social support, let's say family, friends, would you encourage people to bring them around the table to do the plan, or just do a one-on-one? Yeah,
so typically the way that I mean, it depends very much on the person, but I typically like to do it alone with the person, because you say this is somebody you don't know. This is your first or second encounter with the person, and they have somebody with them. If you invite that person in, you have no idea if that person, I mean, they have accompanied the person, but if that is a person they would really turn to for help or as a distraction or what. And so I really like to do it alone with the person, and then invite them either in person or when they go home to share it with other people. Sometimes people want somebody else to help them do it. Like sometimes you'll see within the veterans, like if they have their wife with them, they'll want the wife to kind of to be a party to it. But if you think about it, like, I had somebody who said, oh no, I would never turn to my wife, and it was for help, and his reasoning was, I'm already a burden to her. If I turn to her in this way, I'm just going to feel worse. So, fair enough. I mean, you could work with the person on that, but if you have 45 minutes where you're doing this, it's like, okay, so if you don't want to have her, are there other people? And so she's sitting in the waiting room, and you don't want that person to feel like they have to put that other person on the plan. Does that make sense?
Okay, so thank you very much. I think we are running out of time, so let's thank Dr.